our.
Welcome, everyone. I'm Raj Dave from Camp Hill, Pennsylvania, chairman of the C3 course. First of all, I want to congratulate Hellenic Society of Cardiology for their seminars, and I wish you all the great success. I also want to thank Dr. Tazikas, the chairman of this session, as well as Dr. Nikas, who has given me a very kind opportunity to discuss carotid artery stenting. I've been performing carotid artery stenting since the year 2000, and I've done 2,600 carotid stent cases transfemorally. And has been involved in many carotid stenting and embolic protection trials in the United States. And it's really a great day for patients in US that now CMS, which is our Medicare agency, has approved the reimbursement for all the subsets of the carotid stenting. So in the next 10-12 minutes, I'll give you an overview of where we are with the carotid stenting, and it's really a very exciting time. So I'm going to share my slides now. Thanks again, and we'll start discussing the topic. So these are my disclosures. This is as of October 11th, 2023, Center of Medicare Services, in a final decision, it expanded coverage for reimbursement for standard risk as well as high risk patients and asymptomatic as well as symptomatic patients. So that's a significant improvement in the coverage than what it has been for last 2 decades. Stroke remains a very important financial burden to the Medicare. This is a data from Medicare that was published, and you can see this is our stroke statistics, that in United States, stroke deaths have increased 24% from 2010 to 2020, and it is expected by 2035, the cost related to the stroke will reach $95 billion, which is a staggering amount of money. And carotid artery stenting procedure brings a relief to a big problem. It's not prevents every stroke that's out there. However, it's an important piece in the puzzle. You all know there are multiple ways to treat the carotid artery disease, either medical therapy, endarterectomy, transfemoral carotid stenting, and TCAR procedures. This is a very important data set since the carotid artery stenting trials had started from year 2010 to 2015. There has been reduction in endarterectomy as well as stenting, both procedures. CEA, especially for asymptomatic patient, had gone up slightly. However, carotid artery stenting for asymptomatic patient had declined, and the percentage of symptomatic patients being treated with CEA and CS both had increased. So you can see there is an evolution in our understanding of the disease and the treatment being provided. Moreover, the 30-day stroke and death rate with both procedures, with more experience, more understanding of who does well with these procedures, have gone down. So you can see with carotid endarterectomy, starting from 1970 to 2016, the 30-day stroke and death risk had reduced down to 1.7%. With carotid artery stenting, very similar, between 1 and 2%. Increased volume and experience have also made a substantial difference. Since there has been increased access in the United States for the carotid stenting procedures because of FDA approvals of devices as well as the CMS coverage, there is a 30-day stroke and a death risk also has improved from 5.3% to 2.6%. And the number of patients enrolled in the trial in 2004 were around just 1,400 to almost 35,000 patients in 2010, leading to more volume, more operator experience, lower complication rates. There has been more advances in the embolic protection, stent technology, and the understanding of the anatomy of who does well with these procedures. Let's look at the 30-day clinical data of the randomized trials between carotid artery stenting and endarterectomy, and you can see that both procedures did very, very well, and the stroke, death, and MI rates have been very similar to both procedures between many, many studies that I have listed here for you to see. This is the most recent data. This is from CREST-2 registry. And you can see that the stroke and a death risk for either in asymptomatic as well as symptomatic patients with carotid artery stenting achieved a very low 1.4% for asymptomatic and 2.8% for symptomatic patients, a very acceptable risk for carotid procedures. What about long-term results? Because a lot of patients, they come and ask us, whether if they have a stent versus surgery, what is the long-term stroke prevention? And this is the CREST 10-year primary composite endpoint data looking at stroke marker of infarction and death and subsequent ipsilateral stroke. And you can see that there is no evidence of difference between CEA and CAS. So both procedures remain very effective in preventing a stroke. It's very important to remember and to remind everyone about the potential high-risk patients for carotid stenting, and there could be a clinical high risk and an anatomical high risk. We generally believe the more elderly the patient, more complex aortic arches, the more atheroma and calcification in the aortic arches, or there is stenosis at the origin of the great vessels, you have higher complication rate. Also, if you have very severe bends and very calcified lesions, if there's a thrombus in the lesion, also increases a potential risk. Lack of appropriate femoral access also increases potential risk. Decreased cerebral reserve and dementia in any very elderly patient also increases significant risk and should be avoided if possible. Here is a case example. This is an 81-year-old gentleman with a prior history of left carotid endarterectomy in year 2018. He has prior history of stroke in 2015, has history of hypertension, hyperlipidemia. He was referred to us because of bilateral carotid artery stenosis. He had restenosis in his left carotid artery at the site of a previous endarterectomy, and which led to patient evaluation. Patient was having TIA symptoms on dual antiplatelet therapy. Here's an angiogram. You can see the clear-cut severe stenosis. Important thing that I would like to point out here is that you can see here that the cervical portion of the internal carotid artery is a very nice straight vessel. There is focal lesion. The common carotid artery is very straight. These are all favorable features for carotid artery stenting procedures. There's no kinking, very straightforward. Here is an embolic protection device. This is a NAV6. Abbott system, which is the primary system that I use in my practice. And after the placement of the filter, this was a closed cell design exact stent, which is my favorite carotid stent system currently. Was deployed. You can see there's a very nice coverage of this stenosis and an excellent result. And a patient became asymptomatic and remains asymptomatic. This is a 2-year follow-up, and you can see there's a wide open stent, post carotid stenting, showed very nicely. So in summary, the stroke remains the 5th leading cause of death in the United States, and revascularization should be offered to patients prior to the point they become symptomatic and disabled. The treatment approach for carotid artery disease should be tailored to the patient based on their anatomy, their risk profile, and their symptom status, as I have delineated in the prior few slides. The carotid artery stent outcomes have improved over time and demonstrated comparable outcome at 30 days, as well as durability up to 10 years. The recent CMS coverage ruling in the United States will expand patient access to carotid artery stenting procedures and removes restrictions for operators and the hospitals. And these are some very, very important changes in the US market. So with that, in the interest of time for the Congress, I'll stop here. I wish you all a wonderful good luck in your journey of carotid stenting procedure. It's a very elegant, superb procedure. It takes really anywhere between 7 to 10 minutes for us to do carotids now. And once you do 40 of these procedures, you get so good at it that you'll be very happy delivering this care to your patients. And thanks again for this kind invitation.